Hi, thanks.
Of Prof. Michael Lee.
Right, we'll cut off one. Okay, good afternoon, everyone. It's a tremendous honor and privilege to welcome you all to the first live web air organized by APELS, Asia Pacific Endo-Laparoscopic Surgery Group. We have received 326 registration to our Zoom web air today, mainly from surgeons and fellows in the Asia Pacific region. As a medical academic group, APELS has been organizing various types of physical training workshops in the Asia Pacific region the past 5 years that inspired many surgeons. We are now emerging into a new era. I'm proud to see the host of effort to organize a high standard and interactive web air, an event that capitalizes our strength and realize our commitment to you, to cultivate an intensive learning culture and enhance professional competencies in endo-lap surgery in order to meet the ever challenges in today's clinical areas. The 2.5-hour web air today will be put in two key parts. In the first half of the event, we capture the essence from APEL's legendary workshop, with the presence of our 4 renowned speakers from the region, Professor Sukhani, Professor William Chui, Ling Chen, Dr. Alfred Alan Buenafe, and Professor Craig Lynch. Second half of the webinar will include case sharing session from the enthusiastic doctor who submitted a surgery video for discussion with our panel, the Endo-Lap expert, Professor Simon Ng, Professor Jin Kim, Professor Dr. Junhan Lai. As the chairman of APELS, I look forward to the rapid growth of the society and wholehearted commitment to educate, train, and innovate in every aspect of endoscopic and laparoscopic surgery. I must sincerely thank the 2 chairmen who put in a lot of hard work to organize this program, Professor Sukhani and Joe Fan. May I remind everybody we should stick to time and finish this session in 2.5 hours time. Otherwise, nobody's any interested in attending this meeting anymore. Thank you very much. I hope you enjoyed the meeting.
Thank you, Professor Lee, for your introduction. And since this is our first webinar meeting, we'll have some funny idea. So we have invented a kind of a polling system so that during the time of presentation, we'll have some polling section so that you can express your view on different topics. So maybe Karen is here. So can we have the first questions to our audience? So there's some warm-up questions for you, and please click whatever is appropriate. For example, where you hear about our APELS webinar, and what's the expectation, and do you think the current COVID-19 pandemic will change your surgical training forever? Because supposedly this meeting is supposed to be held in Seoul this year, but because of the COVID, we have to make it in the internet platform. But we believe it will meet very soon. So we have some time limitation for your polling. So everyone, please kindly give your opinion or your advice on this. So where you hear about our webinar and what you expect you can get from us. So meanwhile, maybe I introduce our today's panel speakers of the lecture speakers, like the Professor Sukhani from Seoul, also the co-chairman of this event, William Chen from Taiwan. William is here, and also Professor Alfred Allen's here, and also our Professor Craig Lynch from Australia. So maybe we can stop the polling and then you see the result. Oh, so most of us think heard about APELS webinar from their friends and colleagues, probably from our experts here, and also they expect to learn about some latest technology and skills, and also improvement in communication management and make connection with experts and friends. I guess we'll have fulfilled all your expectation by the end of this webinar. And we all think that, most of us think that it will change our future surgical life training, and probably will be more web-based, and we don't need to meet in real life very often, but we have more meetings instead from the internet platform. So without further delay, I would like to invite Professor Sukhani, our co-chairman of this event from South Korea, and today's topic presentation will be the panic guideline during the pandemic. Does smoke matter? Professor Sukhani, please. Hi, Professor Lee.
Yes.
Oh, yeah, we can hear you now.
Oh, thank you. I just turned it on the microphone. Thank you. Good afternoon, ladies and gentlemen, Mr. Chairman. I'm really appreciate for the opportunity of this first APELS webinar. So today I'm going to talk about the recent guideline during a pandemic, and then think about some concerns about the smoke. I have no disclosure. I just had a couple of experience of the screening work during this pandemic season. Actually, there are a lot of impact on surgery during the COVID outbreak. This slide shows the brief Instagram, the graphic of the impact, like the cancellation of the scheduled surgery. Sometimes we face the shortage of the blood component, and then if there are a lot of COVID patient occurred, found in the community, sometimes surgeons shift to the other areas. So we surgeons are not doing the surgery, but we just help the intensive care unit patient, and then we will help the public. And then there are a lot of problems like a post-operative surgical care, and then we should establish some COVID-19 surgical pathway in order to keep the operation room safe for the rest of the non-COVID patient. So there are a lot of concerns during this pandemic season. Recently, the international COVID surge collaboratives, mainly in Europe, analyzed the data of the COVID positive patient, especially the mortality and pulmonary complication. Based on this publication, only 26% of the patients were pre-diagnosed with COVID preoperatively, and then among them, pulmonary complication occurred more than half. Surprisingly, 30-day mortality rate was 24%. So these pulmonary complication accounts about 80.82% of all deaths. So this paper recommended postponing non-urgent procedure and promoting non-operative treatment and delay or avoid of the unnecessary surgeries. So we are facing a lot of problems. One of the problems is, can viruses transmit via smoke during the surgery? Actually, the answer is yes. There are some reports, the case reports, about the transmission of the virus during the surgery. This is the one very famous report. Actually, the gynecologist with 30-year history of laser ablation and LEAP subsequently developed HPV positive lung cancer. Actually, the reason for this lung cancer was the transmission of HPV virus via smoke, actually laser plume. There are another report. This is a report from South Korea, and then this group reported during the surgery for the hepatitis B virus positive hepatoma patient, the hepatitis B virus can transfer via smoke to the surgeons. So we should be very cautious about the control of smoke during the surgery, especially patients are COVID-19 positive or hepatitis B or HPV virus positive, like this. This is the question to you. Where are the COVID virus found in our body fluid? Do you think saliva is okay? Saliva, are they present? What about sputum, blood? bile, feces, urine, and CSF. Among them, the urine and CSF, we cannot find any COVID virus. However, we can find COVID virus from saliva, sputum, blood, bile, and feces, because we are most of us are, I think, the colorectal surgeons. So if we are dealing with the transanal surgery or something like that, we have a chance to get the COVID virus infection if patient is COVID positive. Think about the particle size, the virus particle size of the COVID-2 virus. This is the RNA virus, and then the size of the virus ranges from 0.06 to 0.14 micron. So the usual HEPA filter, which is installed in most of the operating room, cannot filtrate the COVID-2 virus. So in order to filter the COVID-2 virus, we need ULFA filtration system, which is effective up to 0.12 micron of size. So in order to effectively filter the COVID virus, we need ULFA system, ULFA filter system during the operation. Actually, many Western companies for the TROCA system. However, unfortunately in Korea, we do not have any ULFA installed TROCA system, the filtration system in the OR, I think. This slide shows the high-risk procedure for visualization and potential viral particle transmission. Of course, bronchoscopy, endotracheal intubation, and then here we have the laparoscopy and then colonoscopy also. So we should be very cautious in theory. So if we have a patient with COVID positive, we should set up some flow of those patients. So for this COVID-19 positive patient, we should place the patient to the negative pressure room other than the positive pressure room. Usual operating room is positive pressure room. However, this COVID-19 patient or severely infected patient of other causes, we should place the patient to the negative pressure room. And then for the laparoscopic surgery, initially, many European and American surgeons recommended not laparoscopic surgery, but open surgical alternative. And then they recommended smoke flume suction with inline filters. So this is the original recommendation from the pandemic season at the very first time, but there is no special, there is no solid evidence of viral transmission during the laparoscopic surgery now. So there are a lot of concerns about the smoke evacuation during the laparoscopic surgery. So if you look at the recent publication from colorectal disease, you can see this video. This video is about 10 minutes length, so I will skip. I will show just briefly.
Is still possible. The most important things are to have in the trocar smoke evacuation system all over surgery, and secondly, at the end of surgery, when the gas is stopped, it's important to evacuate. It's important to evacuate smoke with suction device as this one, and until the abdomen is completely desufflated, we will not proceed to the extraction mini laparotomy or to removal of trocars.
Okay, for the time limitation, I will stop this video, and then we should be careful during the surgery to take care of the smoke, as I show you in the video. And then, if we have a lot of patients, we should triage our patients. So this is the priorities of the important things. So we just categorize the clinical pandemic condition in each country, and then we should make some patient flow, prioritize the cases like this. For the phase 1, we can do most of our surgery. However, for the phase 3, actually there are a lot of COVID patients, so the community hospital cannot deal with all the cases. In that urgent, emergent situation, we should operate only the emergency cases, like a perforated, obstructive, or active bleeding cancers, or the cases with sepsis. After the surgery, we have to make some patient flow diagram as shown in this slide. So during the operation, we should describe what to do, and then we should share the information all together, including the nursing steps. So this is the SAGES and EAES recommendation during the COVID-19. So after we pursuing the evidences, so there is little evidence of minimal invasive surgery risk specific to COVID-19 ever period. So we should be very cautious. However, sorry. So in conclusion, Mr. Chairman, ladies and gentlemen, some elective surgeries like a cancer surgery or a C-section and most non-elective surgery must continue throughout any pandemic. And if the prevalence of COVID-19 is low and the hospital resources are coping with demand for the ward of an ICU bed, more elective surgery can recommence. Thank you very much for your kind attention. Thank you.
Thank you, Professor Lee, for your nice presentation. Because of time limitation, we'll leave the Q&A section after 4. So may I invite our next speaker, Professor Alfred Allen, a good friend from Philippines, and his topic will be on Endo-Lap approach in the colon surgery, ELS. So Alan, are you ready? Yeah, seems you're well prepared. You have a professional team behind you.
Thank you, Joe.
Yeah.
Can you hear me now?
Yeah, sure.
Okay, thank you. Karen, Kadora, can you spotlight on my video, please? I'll share my lecture on the video. Am I on spotlight? Okay, good. Anyway, can you see my slide now?
Yes.
Okay, you can see now my slide, right? Okay, thank you. Good afternoon. I'm Alfred Buenafe from Manila, Philippines. And my lecture is about endo-laparoscopic approach for colon surgery, or what we call CELS, or CELS, combined endo-lap surgery. I don't have any disclosures. So anyway, in recent years, we've seen a lot of advances and a lot of changes, especially in the surgical care, particularly in your endoscopic treatment. So much so that advances in endoscopy have made a huge impact on gastrointestinal disorders, even providing alternatives to your traditional surgical options. Nowadays, for every surgical condition, open surgical condition, you have a endoscopic management that would correspond to each open surgical option. The more familiar endoscopic procedure especially for a obstructing common bile duct stone. Now you have an ERCP, an endoscopy, endoscopic retrograde cholangiopancreatography for obstructive jaundice. And just another example would be your PEG or PEJ for enteral nutrition. Your ESR and ESD for gastrointestinal polyps, mainly gaining more popularity because of its advantages to your patient, like your shorter hospital stay, quick recovery for your patients, and the use of your normal body orifice, which would now then would end up with your patient having no scar after the procedure has been done. Initially, your EMR and ESD is being done on the gastric area, but nowadays can be done even for your lower GI tract or for your colonic lesions. On the other hand of the spectrum, you have your laparoscopic surgery, also a fast developing field and being more popularly being used now, especially by young surgeons, being used more successfully as an alternative to open surgery because of the advantages and the advantages for the patient, providing better solutions to varied surgical conditions. But despite the advances and innovative techniques of both disciplines, your endoscopy and your laparoscopy, there are still some limitations to both procedures. Endoscopic procedures are sometimes not suitable for large or near circumferential lesions. Quite difficult to do your endoscopic procedure. May be technically difficult at flexures behind your mucosal folds. For laparoscopic procedures, on the other hand, your lack of tactile sensation may have difficulty locating early lesions in your GI tract. But now again, if you combine both endoscopy and laparoscopy and utilize the advantage of both, then we might overcome these limitations and come up with a more superior procedure. Hence, you have your CELS or your combined endolaparoscopic procedure. As early as January 2005, the first Endo-Lap OR in Asia was already developed by the group of Professor Michael Lee in Hong Kong. A paper by their group showed that the advantages of your combined Endo-Lap would show a decrease in overall workload. It also acknowledges the advantage of combining the benefit of both specialty fields. It revolutionizes not only elective surgery cases, but also in their study have shown you can use also combined Endo-Lap surgery even for obstructing colonic tumors. We all know that obstructing colon surgery can occur in as much as 30% on the left side of your colonic cancer. It can present as an acute obstruction. Majority of these are in the sigmoid or rectosigmoid area. And the traditional surgical management would include either a diverting stoma, an extended or a subtotal colectomy, with or without anastomosis, or resection with end stoma creation. But in a lot of our patients, especially in the Philippines, in reality, or especially for compromised patients would just end up with just diversion to relieve the obstruction and just to tide over your patient. And finally, in about 30% of these patients having a diverting stoma, they don't undergo any reversals anymore. Over the years, your self-expanding metallic stent have become more popular as a therapeutic option for your obstructing colonic tumors. Several multi-center randomized controlled trial has been published providing high-quality evidence for its use as a bridge in laparoscopic surgery. A paper from our very good friend Hester Chung from Hong Kong again, from the group of Michael Lee in 2009, published the world's first randomized controlled trial comparing the outcomes of endolaparoscopic approach with those of open surgery in the management of obstructing cancers in the left colon. And they published in their study, after a randomization of matching patients presenting with left-sided colonic obstruction, on one side a laparoscopic group and on the other side an open surgery group for emergency surgeries. The results would show that in the stenting group, you have less cumulative blood loss, less wound infection, less dependence on pain medications of the patient, a less permanent stoma, and a more successful outcome of a one-stage procedure for patients. These findings led to the conclusion that metallic stents really would serve a safe and effective bridge to a subsequent laparoscopic surgery for obstructing left-sided colonic surgery. The combined Endo-Lap approach makes a one-stage operation more feasible, reduces the incidence of your stoma creation, and allows patient the full benefit of your minimally invasive surgery. This is quite a busy slide, but suffice to say that this study would show you a lot of larger randomized controlled trial can show you all the benefit of a combined endolaparoscopic approach. So meta-analysis would just show you a lower post-operative complication and morbidity rate for patients, a lower direct stoma rate. There's no difference in primary anastomosis rate in the two meta-analyses. No difference even in anastomotic leakage, and there's no difference in overall mortality or morbidity in your patients. So the findings for oncologic outcomes include there's no difference in local regional recurrence, no significant difference in 3-year disease-free survival, and no significant difference in the 5-year survival rate for your patients, and no difference in your recurrence rate. So after compiling all of these studies of high-quality evidences, the European Society of Gastrointestinal Endoscopy came up with an updated 2020 guideline. And their recommendation is to do a stenting as a bridge to surgery, laparoscopic surgery, mind you, as a treatment option for a potentially curable left-sided colon obstructing colon cancer, and as an alternative to an emergency operation. So this is just one of our videos that we have done in our center. This is a CELS placement for a 90% obstructing tumor on a sigmoid tumor. The reason why we chose this one, I'll just move the video forward in the interest of time. So insertion of a stent was done on this patient and to tide over the obstruction. After the patient has been prepared and tied over, we scheduled the patient for surgery. For the plan of the service is to do a one-stage procedure. So after successful decompression and preoperative preparation, the patient underwent a one-stage laparoscopic procedure with a therapeutic intent. So if you notice in that video, the tumor was quite adherent to the part of a small bowel. The small bowel is quite adherent to that area of the tumor. So if you have a obstructing tumor on a patient going for an emergency surgery, more often than not, you won't be able to do the procedure because of a quite enlarged small bowel. But with this video, we're able to successfully resect, including the small bowel, and do a end-to-end, side-to-side anastomosis of that small bowel. We chose to do an end block resection of the tumor together with the sigmoid tumor. So that's the anastomosis of the small bowel. Then we proceeded with an oncologic dissection of the tumor, identifying all the important structures. So this is now your ureter. We're able to identify it. Following your line of thought, I'll just again move the video forward in the interest of time. So after identifying everything and trying to dissect on the surgical field, we were able to successfully resect the tumor. So a distal sigmoid tumor was then dissected and resected. So I'll just show you the anastomosis we're able to resect now. So this is the anterior resection now of the tumor. Removal of the tumor with the protection device, wound protector. And we were able to do successfully an anastomosis of the bowel. So after anastomosis, you can do an intraoperative colonoscopy just to check for the anastomotic site, inspecting for bleeding and possible stapler malfunction or disruption. So you can do your repair if you notice any malfunction or possible bleeding in this area. This is done ideally with a carbon dioxide insufflation. Again, for a combined endolaparoscopic approach, another advantage is the use of your laparoscopy in trying to locate for smaller tumors. This patient was scheduled for a single port sigmoidectomy for a small sessile polyp that came out as a adenocarcinoma. Again, I just moved the video forward. So once you've identified the tumor, the placement of the tumor, you can do a combined Endo-Lap again. So this is a usage of a endoscopy or a colonoscopy intraoperatively, just to be able to identify where the tumor is. We all know that in laparoscopy, you lose that tactile sensation, so you won't be able to identify where the tumor is unless you can do an inja-ink tattooing of the tumor. So once we were able to identify where the tumor is, we then proceeded with the resection and the anastomosis of that area. So again, end-to-end or side-to-side anastomosis was done on this patient with a single port device. So patient, after 3 days, was sent home markedly. So we're able to do a single port sigmoidectomy on this patient. So as a summary, in summary, stenting as a bridge to surgery and your combined endolaparoscopic surgery is actually an acceptable or even a superior treatment option for a left-sided colonic obstruction. We've done some of our procedures even for a right-sided obstruction. We do some stenting on this patient, and we can do a one-stage procedure for a patient. It is a safe alternative to emergency resection. Minimally invasive surgery in the lower GI will continue to evolve, I think, to improve with combined Endo-Lap surgery, and it can be applicable to both elective and emergency conditions. So, in conclusion, Mr. Chairman, the synergistic approach of both disciplines would allow for a healthy discovery of new ways to improve patient care, while at the same time allowing exploration of new and exciting frontier for the advancement of surgery. Thank you very much.
Thank you, Alan. Thank you for your very nice review of the current application of endolaparoscopic surgery. So again, we'll leave the Q&A section after all the lectures. May I now invite Professor Chen? And you ready now? Yes. We can see your screen now.
Can you?
Yes.
You can see my screen now, right?
Yes, yes, yes.
Okay, sorry for the technical problem with you. Okay, can you see the screen now?
Yeah, sure.
Okay. Now today I'm going to talk on the new training paradigm in laparoscopic colorectal surgery. And, oops. Okay. Well, I think the old way of training, the Hosted way of training has been the past. I think it's been varies in experience, and you practicing a real patient and a mentor is not validated, and it's insufficient. And nowadays, if you train like the way, the Hosted way, I think the OR cost is too expensive. I think over the past 25 years, digitalization, miniaturization, and improvement of optics and novel images, techniques, and computerizing the operating room has changed our practice. And surgical education fails to keep up the pace with technology. So without the skills to stay useful as innovative variety, surgeon suffers, and even if enough of them fell behind. So surgical societies started to fall apart. So we have to keep attention on this. So I think surgery is hard to teach. It is not all that easy to learn. I think only 5% of the surgeons are gifted hand. I mean, I don't think a surgeon is born. I think the surgeon is trained. So we used to train like this, basic and general knowledge and OR training, board certified and practice to become a master. So this is the old way of training. And the old way of training is also like when we're doing residencies, you're a novice, you're unconscious, incompetence. And then when you are a fourth or fifth year, you probably be conscious and incompetence. But when you are a fellow, you probably be conscious and competence. But now, if you're being a master, we have to be unconscious and competent. And this is the stimulated base of training. And this is not a good way of training. Even though you can't keep up with the current days, the challenge that the complexity of the surgeries and sub-specialization and 80-hour work time and OR resources and time has limited, and public awareness of about, they call it medical legals. So the new issues in medical, in the MIS era, probably you have to talk about ethic, patient safety, learning curve, standardization, quality of the training center, and quality of your teacher. So we need to change. So how are we changing? Okay, we need a fast change. We need to standardize our curriculum. We have to work on a professional-based and team-based training. So it is a standardization training versus time-based acquisitions of experience. So we should train our resident like a competence-based training. Your ability, your skill, and your knowledge should all put together. So not necessary if you're the first year or second year residents, not necessary that the second year resident is better than the first year resident. So the way we train, it's all depending on the ability of the trainee. So what do we train? We train of patient safety, we train of utilization of the instruments, adequate positions, and we recognize in the laparoscopic or minimally invasive anatomy. And we train of how to suture, and we train of how to manage intraoperative complication. And the most importantly, we train of teamwork. Because laparoscopy, you have to do it with team, not just yourself. So in China Medical University, we installed the 6 sports awake like surgeon course. So it is combined with ACGME accreditation and our 6 power force, which is the knowledge and care and presentation and research, teaching, and skill. And today we're just going to focus on the skill, how we train our residents. So we train like the dry lab and Endo-Lap, and we follow the OSET and all the guidelines of other. So we train our resident like a basic open skill and laparoscopic simulator, and then we take the resident into laboratory and cadaveric workshop. So for open basic skill, we have courses to train. So usually we train with like inanimate model, animal model, cadaveric model, and pop trainer and virtual reality. So this is the benefit of it. The inanimate model is cheap. It can be reused and accessible. And this picture is my dad and I. I taught my dad how to do laparoscopic suturing during the time I conduct a workshop. And he really likes it, and he thinks that he could extend his surgical life if we have minimal invasive surgery back then. So we also trained of, this is how we train the resident. So we train of how and then we also train the laparoscopy operating, how they hold the scope and how the scope works during the operation. And also we have a colonoscopy operating training, which we send our trainees to APELS. And then we train like virtual training. And all this training here, a lack of realism and can only stimulate the most basic task and difficult to monitor progress. And we train at the Taiwan for animal model and also APELS. And the benefit is more realistic, especially the physiology part, and closer to realistic anatomy. And complex, you can do more complex procedure and more realistic working environment. But the limitation is expensive, and And nowadays, it's the animal care like society would think it's unethical to do it on animal, and it's difficult to monitor the trainees' progress. So, and we also this is how we do in our institute and cadaveric model. And nowadays we have cadaveric training in the AirCut Taiwan, so we do that with the AirCut, and we train with the TME workshop in AirCut. So, and these are more realistic anatomy, but expensive, no physiological things doing your surgery, and it's unnatured tissue properties and difficult to monitor progress. And we also train at the APELS. Trainees have a chance to use the POP box, and this is one of the better way of training. And virtual reality, the stimulator. I think these you can repeat doing the skills that you can preset the computer, and you can allow you to see your progress, and it's less psychologically stressed. And I think the trainees likes this better, but it's very expensive of buying these virtual reality things and computer guided throughout the other procedures. So I think it's more ethically sung for this type of training. So, but the limitation is the complexity of organ modeling is not available, and the limited range of motion and lack of tactile sensation, lack of depth perception, and lack of force feedback. And for the novel surgeons and medical students, I think it's only for novel surgeon and medical students. And I think potentially don't have a reality, and it's very expensive. The machine is expensive. Software is also expensive. And live surgery is also a new way of training. You watch live surgery, but live surgery is really harsh. I think witnessing and live surgery is more exciting than watching a video because it is because of its uncertainty. I think human nature still lives with the witness of dangers, and especially danger to others. But it is ethically challenged, but an expensive learning. But I think it is also always pleasure to watch live surgery. After live surgery, you have to go back to the real ward, and then usually I take my resident and one by one, step by step, so we can have them to get used to it. But nowadays, we have a digital learning, an online course. I think it's another way after COVID-19. I think this is a very good way, and I think APELS provide a very good platform for us to learn. At the end, I would like to conclude that I think there is still room for training. Techniques, instruments, and technology is coming. I think innovation is important. Training outside of OR, and then go back to OR, or else it's too expensive. I thank you very much for the invitation.
Thank you, William, for a nice presentation. May I now invite our final speaker, Professor Lynch. His topic will be on fluorescence-guided colorectal surgery. Can you share your screen?
Yep, I will. I just have to unshare William first.
Please escape. Stop sharing your screen.
Good stuff.
Okay, yeah.
Well, thanks, Joe.
Yeah.
I'm going to be talking briefly about fluorescence-guided surgery and how it can affect us and help us when we're troubleshooting with colorectal surgery especially. Now, what we can do with it is it gives us an opportunity to get real-time visualization of blood flow in tissues. So this means we can see vascular anatomy, but also get an idea of tissue perfusion. So useful if we're planning an anastomosis, or if we've had a surgery, we were dividing adhesions for a bowel obstruction, and we want to see if we have viable bowel after a band adhesion, say. And it's also useful to identify structures during surgery like ureters or bile ducts or even lymph nodes if we're doing an extended dissection. So it can help us prevent complications by identifying the structures early so we don't damage things, and also prevent complications long-term by reducing things like anastomotic leaks. Now, the dye we use is ICG. It's been around since the 30s. It was used to make colour photography early on. It's quite safe, not very toxic. What it does in the vessels, it binds to proteins in the blood. So it stays in the blood vessels, which means we can outline the blood vessels before it gets into the tissue and then through the lymph back to the liver. It doesn't last very long in the blood, so it means we can use repeated times during surgery, and it's excreted in bile. So if we wait, it's also very useful for hepatobiliary surgery because it can outline bile ducts very well for doing laparoscopic gallbladders and things. So how does it work? We've got our little molecules of ICG, and if we excite those molecules with near infrared light, then electrons get excited and move up to higher orbits. And then as they drop back down to their normal orbit, they release light in the form of fluorescence. All that extra energy they've had is released, and then we can detect it. So what we've got is we excite it with one wavelength of light, and then we can detect the fluorescence, which comes back as another wavelength. So during surgery, what that means we need is something to generate the near infrared light, and that's either a laser or a filtered light source. And we need the dye, and then we need a detector to detect the fluorescent light coming back. So that's often built into a laparoscopic tower, or it can be as a handheld system, or it can be on a robotic system, for instance. There's a number of different systems that do it. And if we have those three things, then we can see the fluorescence, and the dye that's in the blood vessels transmitted through tissue so we can see it. We normally give a dose of about 0.1 to 0.3 milligrams per kilogram. There's a wide range between what a maximal dose is. And as it goes through the blood supply, normally we can see it in less than a minute. It does cross-react with iodine, so we have to be careful if patients have an iodine allergy. So how does it work? So here we are, we've got a bit of colon that we've dissected the blood supply away from, and we want to work out where we're going to do our anastomosis. We want to see which bit has blood supply. So we can look at it visually, but also with the ICG. We can see that it takes some time to get through the circulation. And here it comes, and you can see it in the blood vessels, and then it perfuses out to the tissue. And clearly on the right side, no perfusion, that looks dead. There's a bit of an area where it's patchy, and then over on the left, it looks like it's got a good supply. So that can help us choose where we're going to divide the bowel and what we're going to use to try and make a healthy anastomosis with. Now, it's not just as easy as looking at what glows green, because the rate of change and the intensity of change is probably very important. And we don't have a lot of data or a lot of ways of being able to identify this at the moment. And this is something that artificial intelligence and AI and various algorithms are going to help us a lot, so that when we see the dye come through the tissue, we'll get a good idea of the actual degree of perfusion and how useful that is. And once it's gone through the blood vessels, it goes out through the liver and into the bile. So if we look at the liver, it could look really green. So there's been some quite good studies. Probably the biggest one that's most well known was Pillar 2. This was prospective, and it looked at the anastomosis during colonic surgery and whether the surgical plan was changed by using ICG. And this happened in about 8% of cases, so not many. And most of those were when the resection margin was changed to somewhere more proximal. And there was only one patient where the anastomosis didn't look good after it was done, so it was revised. But interestingly, that study had a very low leak rate of only about 1.5%, which is very low. And none of the patients where the surgical plan was changed had a leak. And we know how catastrophic leaks can be for colorectal surgery, so that's certainly very encouraging. And the only 2 leaks they saw was when they thought it looked satisfactory. So a note of caution that just because it might look all right doesn't necessarily mean it won't leak. So it's not the only thing we need to use if we're going to look at this. So when we're doing our surgery, one of the other interesting things is for intracorporeal anastomoses and other stuff we do inside, we're not actually visualizing the bowel. All we're seeing is what we see as the bowel on the screen. So anything we can do to get a better idea of perfusion and how healthy that bowel is quite useful. So here's a bit of small bowel. So it's important to divide the blood supply right out to the bowel edge. Otherwise you'll get ICG going into the resected specimen, which is over here on the right. And then we can turn on the laser light and watch it as the bowel perfuses. And that'll give us an idea of whether we have chosen a correct spot and whether it would be a good place to divide things. And once we've chosen our spot, then we can staple it. So bowel perfusion, very useful, and it's something we certainly could do more of with colorectal surgery. Once we've done our join, we can look at the inside of it. We can insufflate the rectum with a colonoscope. Obviously, we have to use the light source, so often you'll need a laparoscopic scope, but you can introduce that into the rectum as well and look at the mucosa and see if that's well perfused. And if it's not, that's often quite obvious. And if it is looking doubtful, then it might be a reason to either reinforce or redo the anastomosis. Now, other things we can do, which is interesting in the pelvis, if we've got a ureteric catheter in, we can inject ICG into the ureter. Now, ICG is not excreted through the ureter, so we've got to inject it up and then it sticks to the wall of the ureter. And that means we don't have to dissect out the ureter, and we can operate around it with much more confidence because we can leave it deep in tissues and safely dissect away. So this patient's got diverticular disease, and it's sometimes quite hard to see the ureter. So using ICG, we can see it and know that a section plane is clear, and we can just keep operating. And it can keep us out of trouble. And by not having to dissect out that ureter means we might not devascularize it and cause a stricture or a problem later. So for difficult surgery, you can plan ahead and put a ureteric catheter in, and it can save you some trouble. And we can also use it if we inject near a tumor. We can identify lymph nodes, especially in the pelvic wall, which can also help us when we dissect things. So ICG, it's great to see vascular anatomy. So really we can use it to see if we've got good perfusion when we're joining bits of colon together or small bowel. We can also use it to identify other structures like ureters and bile ducts and lymph nodes. The data would say that it can prevent complications, reduce anastomotic leaks, and it's very simple to use. So if it's available and the equipment is there, it's certainly something that is worthwhile. Thank you.
Thank you, Professor Craig Lynch. I guess you have more to share if you've got more time. Because of time limitation, we have a short discussion and a question and answer section. We got some questions from our audience that I guess the questions are applicable to all of us here. So do we routinely perform intraocular colonoscopy to check the osmosis? So any advice from our panelists, from our experts, and from our speakers here? Personally, I routinely do endoscopy.
Actually, in my hospital, I'm doing endoscopy routinely during the left side colon surgery. But for the right side colon surgery, we have less than 1% of leak rate. So we do not routinely perform the colonoscopy for the right side anastomosis.
Yeah.
Thank you.
I think having a colonoscope routinely in theatre for rectal surgery is very useful. If you don't know where the tumour is, you can't find a tattoo, all sorts of things, as well as checking the anastomosis. And it's better to have it available routinely so that if there's a problem, you don't have to go and find one.
That's why it's important to have Endo-Lap OR or Endo-Lap OR equipment, because both the laparoscope and endoscope are user-friendly, plug and play.
Agree, because Michael have been saying that for a long time. So we put a colonoscopy in our OR after rectal anastomosis or sigmoid or anything left colon, and then you find some complications that you can avoid, such as bleeding or like a small defect. We can clip it at the time. So I think it's very important to have a colonoscopy or your endo-laparoscopy in the current OR.
Yeah, agree. Another, I think it's very meaningful questions, I think, direct to Professor William Chen. How do you objectively measure or evaluate the competency-based training for skills in advanced procedure? So do you have any objective parameters for the measurement or evaluation?
Yeah, we have a measurement for our residents that from 1 to 5. So we have like tutors in our residence program. We have several young staff that tutor them, and they have I didn't show it today, but we have like 1 to 5 scoring and rating their skills, and we have like competition on each time we host our training. So we do have seeing their competence based on some grading of their work.
Yeah, I guess it would be nice to have a kind of a international kind of a standard of a competency measurement for all of our colorectal surgeons. Yeah, maybe some questions for Professor Alfred Allen. How long would you wait after the stent insertion before you proceed to your elective operation, and how low the stent you would place for patient with rectal cancer obstruction?
Come again, Joe?
Yeah, how long would you wait after you put the stent for elective operation?
It depends. Even in the paper of Hester and Michael, usually same hospital stay, the longest that the patient would have the definitive procedure is 2 weeks, but really would depend on how fast would you be able to decompress your patient and be able to optimize. Once the patient is optimized and the patient can go for an elective procedure, then you can do your laparoscopy. I think Michael is raising his hand.
From our experience at that time, before the trial start, we realized that it's not to do it too early because the tissue edema has not settled down. So in our later trial, we decided to do it about 7 to 10 days afterwards.
Same hospital stay.
Yeah, still, yeah.
Usually, Michael, usually I do it on the 14 days because our insurance policy is that when you discharge the patient, you cannot readmit the patient after 14 days. So 14 days, I think, is all right.
Yeah.
Yeah, I
not to do it too early. It doesn't matter if you do it later.
Agree.
Yes, yes, I definitely agree with Michael Lee and then William, because if we move the patient too early, we can find there are a lot of edema,
Yes.
edemas of the bowel. So in those cases, we cannot make a primary anastomosis without stoma. So we have to wait about until 10 to 2 weeks. During that time, the proximal dilated bowel will get a lot of rest, sufficient rest to do a primary anastomosis. That's our experience and also our policy.
So I guess 10 to 14 days would be a kind of
Yes.
recommended time for waiting after you put the stent. Simon?
Yeah,
Someone?
another question you raised is about, you know, how low you can stent a tumor, right?
Yeah.
So in Hong Kong, in our unit, I think, you know, anything below rectal sigmoid, we're not going to stent, all right? That means if the obstruction is in the rectum, because patient will complain about a lot of tenesmus afterwards. So for tumor located below rectal sigmoid, we're not going to stent. Now, proximal, well, depends, you know, some people are saying that anything proximal to splenic flexure, that is in the right side of colon, stenting will be difficult, but technically it's feasible. But for us, mostly we will stent, you know, anything between the splenic flexure to rectal sigmoid.
Yeah. Some even do standing for the right side of colon, colonic obstruction.
Yes.
So I got a question or a comment for Professor Hwan Lee. So because in COVID pandemic, we all wearing PPE for operation, but did you find any literature or evidence to show that the cost for PPE, routine PPE, versus to screen the patient before the operation as kind of more effective way to prevent the kind of infection of the surgeons and nurses in the operating theater? So what I mean is that you screen the patient before the surgery versus you choose a kind of routine PPE protection for all the staff.
Actually, for the non-COVID patient, we don't have to wear PPE during the surgery, even this in pandemic.
Yeah.
So I recommend wearing PPE only for the operation who had a COVID positive patient.
So you routinely screen the patient before the operation?
Yes, yes. Most of the hospital in Korea right now, we are doing COVID test before the operation. So we try to keep our operating room COVID free. And if there is a COVID patient, we assign the patient to the kind of the dirty operating room. I mean, the dirty means the operation room for the COVID positive patient.
Yeah, Professor Chin Kim, you got a comment?
Yes, we have a lot of problems considering the PPE during the operation, but we should consider the emergency operation during the pandemic area because the surgical patient, especially in our field, they have fevers before the operations. Even we take the COVID test, we cannot get the result preoperatively, even the patient is negative. So if the patient have a really true emergency condition and patient have a fever, so in that kind of case, we recommend to use level D PPE, including the face shield and N95 masks and waterproof the scrub gowns or etc. 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 So even the patient proved to be in the COVID negative in the future. But anyway, we should protect ourselves with that kind of PPE, I think. And so in that kind of case, we should protect the patient lines, moving from the emergency room to OR, and all the way is separated from the other, and the surgical room is covered by the plastic wraps or that kind of thing. Or that kind of thing is needed, I think.
So how about the case in Singapore, Professor Lai?
Yeah, in Singapore, hi everybody. In Singapore, we have a fair amount of asymptomatic COVID patients, and currently in my hospital, when there is colorectal surgery, that means there is a what we call either upper GI with aerosolization as well as lower GI fecal kind of possible contamination, or surgeries that are more than 30 to 45 minutes long, we do what Professor Jin Kim says, level D PPE. That means a full PPE, and we don't do routine screening for patients because we feel there are asymptomatic patients who have formed clusters in our country. So that's what we are doing. My other question, if there's time later on, is how have you surgeons felt about wearing the PPE for prolonged procedures? There's more than 2 hours. I think there's some comment, especially for myself, that it actually affects your ability.
Yeah, Alan.
Yeah, in Manila, we have a lot of patients coming in who are COVID, either COVID positive or COVID suspect. So in our centers where we do surgery, all the team would have a PAPR. We bought PAPRs for each team member, primarily because of we would want to protect the whole team. We do screening for patients. We also do testing RT-PCR on all patients prior to surgery. But then again, there's a question for emergency patients who would come in for an emergency procedure. So these are the things that are quite difficult. Regardless of the status of COVID, either patients are COVID positive or negative, the whole team would still wear the PPEs, the full PPE. For my team, it's usually the PPR. Too tiring. We started off with the usual full face mask, the bunny suit, the hazmat suit. Our experience, we've done surgeries for 3-4 hours. It's too tiring. It used to be we can do 3, 4, 5 surgeries in one day. But nowadays, if you do 1 or 2 surgeries, it's really taking a big toll on the body, especially when you're talking. For a full face mask and try to talk, try to communicate with your team is really tiring.
Yeah, agree. So my final question to Professor Keith Lynch. Do you routinely perform the use the ICG in your colorectal resection, and does it make your operation much longer than before?
If I've got the equipment available, I'll do it because not every laparoscopic stack will have it available. But if I've got it, I'll use it, and it really takes a few minutes, and it's not long enough to be a difference. You just have to ask your anesthetist to give it, and then you look at it, and then it's done.
Yeah. Okay. Thank you very much. Time's up. I think I will pass my podium to Professor Sukhani to introduce the second section, which is showtime of our trainees. Sukhani, please.
Thank you very much, Joe Fan, Professor Joe Fan. I'd like to start session 2. Actually, this session is a trainee video session. So we ask the trainees to submit their operating video, and also ask to submit some questions of their concern, and then we will watching the video, and then each panelist will talk about the procedure, and then we will discuss further. So please, Professor Joe Fan, please introduce the first trainee to our audience.